What else? What's the other thing you will try to do? Doesn't always happen, but you try to do. You get both beds level, same height. That's not always possible. So you have to go with the flow. So if you think about this as a stretcher, both these tables joined together is about the size of a hospital bed, the width. How are you going to move a patient onto here? So you've got 2 people or 3 people on this side, you've got 2 or 3 people on the other side of the hospital bed. You have to move the patient across.
Use the sheet.
Use the sheet, yeah. But you 2 guys are on the other side of the bed. How are you going to help the patient without doing this? Because that's what you're going to do. You're going to push the sheet while somebody else is pulling, and you're going to end up like this. How do you avoid doing that? What you do is, if you're limber, you get your knee up and you push that way. This is a little high for doing that, but if you can kneel on the bed, you can push without hurting your back. Does that make sense? Because you don't want to do this and you end up lying on the bed. Get my drift? Okay, so that's one thing. The other thing is, I'm having difficulty getting onto this, so bear with me here. I think what I'll have to do is shut it down and start again. Okay, so that's one way. And sometimes in the outside clinics, and sometimes the hospitals too, we have patients that are come in by ambulance. Everybody's seen an ambulance stretcher, right? Do they have locks?
Yeah,
The ambulance stretchers?
they do.
Some of them do, some of them don't.
Just roll around the ambulance.
Well, no, they lock into place in the ambulance. But if you have a patient that's rolling in by ambulance stretcher, and you have to transfer them with hopefully the help of the EMT/paramedics, whoever, to get them onto the bed. Some of these ambulance stretchers do not have locks on them. So be aware. Most of the new ones have, but occasionally if you have people coming in from the rural community, their ambulances may not have stretchers that lock. So what do? How do you manage to get a patient from the stretcher onto the treatment couch when there's no locks on the bed or locks on the stretcher?
Have someone hold it steady. And then
Yeah. So what we used to do when we used to do that was that the people who you'd push the stretcher right up against the treatment bed, and whoever was on this side of the stretcher would put their weight against it so it stopped it from moving, and the other people would just pull. So if you are moving a patient in from a bed onto a stretcher, or from the stretcher onto a treatment bed, or from the bed onto the treatment bed, the easiest way is to use the draw sheet. Everybody knows what I mean by a draw sheet? Anybody who doesn't know what I mean by a draw sheet? Okay, so you use a draw sheet. What if a draw sheet's not available? What do you use? or you want something better than a draw sheet? What do you use? Presume that the patient cannot move themselves. Has anybody ever heard of a sliding board? What are they? Can anybody describe what a sliding board is? What is a sliding board?
There's like the flat boards.
Uh-huh. Okay.
Does it have handles in it?
It has handles on it, yeah. Has anybody seen a backboard? Think of a backboard, only slimmer. And they're usually made of fiberglass. And they're usually friction-free. So you don't want static electricity coming across. So you can use that and put the patient on that, pull the patient onto the sliding board, and then move the sliding board over. However, you cannot treat through those sliding boards. So you have to get the patient off of the sliding board, which means that you have to roll them. How do you roll a patient? What is the descriptive way to use to roll a patient? Has anybody heard of a log roll? No? Okay. A log roll basically is to have, if the patient is lying on the bed, you basically roll him or her all together. You have somebody under the head, somebody under the middle, somebody under the legs. And you do 1, 2, 3 and roll. So the patient comes from here and up to here, all in one roll. Why do we need that? Why is that particularly good?
You can slide the board under them and roll them back on top of them.
That's true, yeah. But if the patient is, the reason why we do that a lot of times is to make sure that the patient is not injured. If they have a problem with their neck, for example, a log roll will roll them in one fell swoop. You don't leave the neck behind, you don't leave the legs behind. You move them as a unit. Does that make sense? So if you're doing that, which person would be the person in charge? Anytime you're moving a patient from a stretcher or a bed to another bed, who is the person who calls go? Like 1, 2, 3, roll, or 1, 2, 3, lift.
Maybe the person who secured the head and neck.
Yeah, that is always the case. If you have a person at the head, he or she is the one in charge because you have this person here. And if you're log rolling them, basically the person at the head does this and everybody else grabs a sheet and you roll like that. So the person at the head always is the person who says 1, 2, 3, go, or on 3, or whatever it happens to be, whatever works for you. So what I'm going to do now is finally I've got into the computer. What I'm going to do now is show you some videos. The program director of physical therapy assistant is going to do 2 groups, 5, since there's 11, right? Yeah, okay. So we'll do 5 and 6. So the first group will be from 10 till about 10:45, and the other group will be after that. So meanwhile, we will do some videos or some PowerPoints, and that will give you a grounding. Now, most of these things are EMS related, so bear with us, okay? I have a video that will show you how to do this, but move this, okay. So. Okay. Let's put the lights out here a little bit. So when Dr. McClafferty says that he's going to teach you how to lift, he really is going to teach you how to lift. And you will be lifting each other. That's why I suggested that you wear stuff that is easy to move in. So we are trying to look at body mechanics. Lift with your knees, not with your back. Keep your back straight. Mental attitude, lifestyle, posture and stress, flexibility. Okay. Check your footing. If you're lifting somebody from, say, a wheelchair, where do you put your feet? How far apart do you put your feet? Do you have them sort of like this, or like this, or like this? Pardon? Shoulder width apart, yeah. That gives you the best position. Keep the weight close to your body, palms up, load is brought closer to your body. Okay, so here are two guys actually doing it correctly. I will put a caveat. I'm not talking about the guys necessarily here, but I have noticed in working with paramedics throughout the US and Canada, a lot of them do not know how to lift. They are not taught how to lift. So these guys are doing pretty good. They're lifting from a low height. They put the patient on a backboard, as you see. Use leg, hip, and buttock muscles, plus contracted abdominal muscles. Reduce the weight or distance that must be moved. So what they've done, if they've lifted a patient off of the pavement on a backboard, they're now putting them on a gurney to put them in the back of an ambulance. So only move a victim or patient you can safely handle. Get additional help if needed. There's a good one. There's usually only 2 therapists, perhaps 3 therapists on a machine. If you have a patient on a stretcher that's come down from the ward, come down from the nursing unit, and he cannot help himself, how many people does it take to move him?
4.
Anybody care to guess?
How big is it?
3
Average size.
on average. Okay.
Average size, maybe 200 pounds. 3, you said?
3 roughly. I mean, that's good.
Okay. Any advance on 3?
5, 4.
4? Okay. So you're looking 2 on one side, 2 on the other?
1 per head.
The answer to that is as many as you can get. So if there's 3 people on a machine and the patient cannot move, you need help. You need at least 4 people. 2 on one side, 2 on the other. Now, if the patient has a problem with the neck, then you need someone at the neck. If the patient has sore legs, then you need someone at the feet, so that you're not hauling and leaving the feet behind. So the average might be 6. So you need help. So 9 times out of 10, in a radiation therapy department, if you have a patient like that, you will hear over the intercom, if there's an internal intercom, lifting help needed on machine, whatever it happens to be. And the people who are not doing anything will come and help, whether they're oncologists, dosimetrists, nurses, literally anybody will come and help. So you can, you need some help. You do not try and do it on your own. If, however, the patient is able to move himself, then 3 people probably is good. So you make sure that the head moves himself, the feet can move himself, and he can shimmy across with his butt. Then you're there just to make sure he doesn't fall or he doesn't have a problem. But don't take the patient's word for it that he can move, because sometimes they'll say, oh, I can do it myself, and they can't. So you have to be aware of that. Keep body in line when moving. So the draw sheet, how far, those of you who know what a draw sheet is, how far down the body does a draw sheet go?
Thought it was their entire body.
No,
It's like
the draw sheets normally
that.
go from about here to about here. So they're only over the bulk of the patient. So if you're pulling on the draw sheet, from here up is going to be left behind, from here down is going to be left behind. So you have to be aware of that, so you don't leave body parts behind. So you have to make sure that somebody is helping the legs and somebody who's helping the head and shoulders. 4 people can do the draw sheet. 1 pulling, 1 pushing, 1 guiding the legs, 1 guiding the head. Don't hurry, the faster you go, the less you think out your plan. Your back is a powerful tool when maintained properly. Once injured, you are 3 to 5 times more likely to experience future injury. I worked with a nurse who had injured her back lifting patients incorrectly, I may add. And about 3 or 4 years after that, she put her back out changing pillows because she bent over to pick up a pillow to change the pillowcase and wrecked her back. So, use bystanders wisely. We've all seen rubberneckers, looky-loos, call it what you will, at an accident site, and they want to help. No. You'll notice that the guys on the cars don't want help, at least not from these guys. So if the patient's family comes in and wants to help, what are you going to do? Maybe say, okay, why don't you just move his feet? Put them somewhere where it's not going to hurt them. Move his feet, just move the feet with us. That's fine. Never ever let them hold the head. Use the feet. They can't do much damage there. So, shoulder width apart. Ensure your feet are flat on the ground. Begin your lift. Okay. So, what do you see on this? I know it's faint. Are the guys lifting with the legs, and what about their head, over their backs? Would you agree with that?
They're doing fine.
Okay. So the backs are straight, although they're bent slightly, but that's because their knees are bent, right? So they're lifting relatively well. Tighten the muscles in your back, tighten the muscles of your abdomen, and the feet have to be flat. Standing position, make sure your back is locked. Okay, emergency move. We're not gonna spend too much time on this because 99 times out of 10, you won't get into this situation. It's a guy getting a patient out of a car. So what do you see? What is he doing?
It's on his arms under her arm.
Yeah, so he's got his arms underneath her arms, and he's got them locked, and he's pulling her out of the car. This is probably because he thinks the car's going to burst into flames. He would not do this any other way. So if we are doing a patient, say in a wheelchair, oh yeah, this is a good one. Okay, this is what they call a 3-man lift. Done this, takes a little bit of practice. Probably you'll never see it done, but it is available. You can do it if you know what you're doing. So this is what they call a 3-man lift. You've got 3 people, one under the shoulders and head. You notice the head is balancing on his arm. The middle one is underneath the butt. The lower one, the other one is underneath the legs and the hips. So what you would do is the patient's lying on the bed, you'd stand there, you'd have whatever bed they're wanting to lift to should be positioned here. So you'd come over here, 3 people in a row, go underneath here, and you'd say, okay, 1, 2, 3, up, and turn, and move forward, patient down. It takes practice, but you would never do that in a patient that you know had problems with their neck, especially their neck. You would never use that lift. So you're walking down the hallway and somebody drops in front of you. And you get them stabilized and the doctor comes and he says, we're fine. Let's get them up onto a stretcher. How do you do that? Patients lying on the floor. How do you lift them? Well, you could do a 3-man lift that we saw before, which is probably a good thing. But you'd have to get down on your knees, or one knee, as the other guys are looking at. You get down on one knee, hands underneath, and lift. And then put them onto a bed. Or you could log roll them, put a sheet underneath them, log roll them back, and lift the sheet. So you'd have 6 people perhaps lifting this patient. Doesn't happen very often, but you occasionally have a patient that will drop onto the floor, and you have to get them either into a wheelchair or onto a stretcher. Questions so far? No? Okay. So there's your 3-man lift. It helps if the people are all relatively the same height. Extremity lift. This is when, if you have a patient in a wheelchair and they can't lift, they can't bear weight. So how do you get them off the wheelchair? This happens a lot. Patients come in wheelchairs. Can you weight bear? No. Can you stand? No. How do you get them onto the bed? Dr. McClafferty will go over this with you, but just so that you know. So you have a two-man lift. One, as you see, they'll put their arms, you put your arms underneath the patient. You see how they're positioned. This is the paramedic's arms, here and here. So they're holding the arms. One's holding here, one's holding here. And you've got them stationary. And then another person will get the legs and you lift. And then the third person, if you have a third person, will pull the wheelchair out of the way so you don't trip over it. And you sit them on the bed. Again, the brakes should be on. Stands to reason. But you have to remember that. So, first paramedic places one hand under each of the patient's armpits, while the second paramedic grips the wrist. Two paramedics pull and lift the patient into a sitting position. Okay? And then the first paramedic holds her arms, and second paramedic is positioned between the patient's legs, lifting, turning, putting down. Always remembering that you don't trip over the wheelchair. What about a patient who is weight bearing so he can stand, he can't move very well? What's that called? Anybody? If the patient can stand with some help, then you can do what is called a swivel. Patient stands up, let me show you. Wheelchair. Wheelchair locked. Okay. So, I need a volunteer. Come on, don't be shy. Okay, come on in.
Why not?
Why not indeed? Okay. So can everybody see what I'm doing? Okay, let me move this over a wee bit. Okay, sit yourself down. So, you just come into the treatment room. You lock the wheelchairs and say, okay, can you stand? Okay, so, can you move? Can you walk?
No.
Okay, good. So, what I'm going to do is I'm going to lift your legs on the floor. Lift your legs on the floor. Okay, so what I'm going to do is I'm going to lift her and swivel her. Okay, I'm just going to do it just a little bit that way. So, what I'm going to do, I'm going to put my feet here. Now, I'm going to put my arms underneath your armpits. I need you to put your hands on my shoulders, not on my neck, on my shoulders. Lean forward.
Do I need any help?
Nope.
Okay.
Okay.
Very good.
1, 2, 3. Up.
Oh, strong.
And turn gently. Now my cohort will be moving that away, and I need you to back up just a little bit and sit.
Good job.
Okay, so go and sit down again.
That was really cool.
It is easy
Yeah,
actually.
she took all the way. I didn't help at all.
It's easy. It's the mechanics. You have to learn how to do mechanics. So what I did was I put my feet between her legs, I bent down, I put my hands over, and I pulled, I swiveled. Do this.
Now, I don't remember, were your hands under my, or
Yeah,
back behind me?
yeah, right behind you.
Okay.
So I went underneath your armpits,
What if they're,
put behind.
what if they're, you know, their width or girth is so large that you can't actually,
I've never come across anyone that I couldn't do that with. And I've moved 350-pound guys. Sorry?
They probably wouldn't fit in the wheelchair.
probably
Yeah,
not.
I mean, we have bigger wheelchairs. We have what's called bariatric wheelchairs, which are big, you know. They're what we used to call big mama wheelchairs, you know, they're about yay wide. I've actually moved a 350-pound guy like that. So it's not that difficult, you just have to know how to do it. And Dr. McClafferty will show you how. So that's the basis. Now, for the two-man lift, if the patient can't weight bear, for example, he can't put his feet on the ground and take weight, then I would come around, bend slightly, put my arms underneath here, and then the second person would grab underneath the thighs, and we would lift and put them on the bed. Let's just move this out of the way for a minute. Stay. That's the easiest one to do, is the swivel. So there is the two-man lift from a wheelchair, but normally we would be facing each other, because we wouldn't have to lift them that far. So, wheel stretcher, scoop, long spine board, and portable stretcher. So portable stretcher, wheel stretcher would be what you see there. I will see if I can find a scoop and a spine board before you guys are finished. I don't think they have a chair. A stair chair is one that you would need if you have, say, the patient's in an apartment and what they call them, 2-floor walk-ups. They have no elevators, they're stairs. So you get a guy they're trying to bring down by ambulance, they have a special chair that they'll put them on, and off they go. We wouldn't have to do that. So the wheeled ambulance, that's the one that everybody notices, everybody's seen. Disadvantage requires 2 paramedics to load and unload. It doesn't have X-ray opacity. You cannot X-ray through this thing. And it's extra weight. This is a scoop. This is a real nice thing. You don't see them very often anymore. But basically, they come apart, the patient sits on, and then they clamp it together underneath the patients. It must be carried, it requires padding, should be rewarmed, yeah. And may consume considerable space. And it is not recommended for patients with spinal injuries for obvious reasons. This is a long spine board. It is a spinal mobilizer. It lifts because you've got handles. Mechanically simple. Some of them are X-ray translucent, so you can X-ray them through, X-ray through it, but you cannot treat through them. And it integrates well, so it can be served as a CPR surface. So what does that mean? why are they telling us that it can serve as a CPR surface? If you're doing CPR, what do you need?
Flat surface.
Pardon?
A hard flat surface.
A hard back surface, thank you. A hard back surface. That would work. If you're on a soft hospital bed, it doesn't work very well. So that's why a lot of people will log roll, put the backboard on, put them down, take the pillow away, and treat. So if you see anybody on the movies doing CPR on a hospital bed,
They don't do
with the
CPR
patient's
right.
head on the pillow, bull. It doesn't work. Our treatment beds actually are very good for CPR. They're real hard. They don't give. Disadvantages must be carried, usually must be left with the patient. Okay. Unstable for moves up or down inclines, patient will slide off. They're uncomfortable, but then they're meant to be uncomfortable. Very seldom do we see wooden ones anymore. But there's still a few around. And maybe we can live time. There's a stair chair. Fit for use in stairways, corridors, or elevators. And some of them you can convert into stretchers. However, they have to be carried. You can't do them with unstable patients. You can't use with patients with what they call altered mental status. And they may consume considerable space. But they're really good. See them in action, really quite good. And a portable stretcher, which is basically the same. Okay. How do we do it? So this is from UT Health, the University of Texas. So one person transfer. The other thing that we should do in that swivel one that I mentioned was that a lot of times the patient will have a gait belt. Has anybody seen a gait belt? Describe a gait belt.
It's like, they have Velcro ones, and they have ones where you can like feed it through. It goes around their waist, and you grab it like that.
Yeah, so that's you can use that to give yourself some added purchase. So the patient wears the gait belt, and if I was doing the lift again, I would lean forward, I'd put my arms around and grab the gait belt, and that helps me to lift. But the swivel also helps the actual mechanics of getting them up. Bed, wheelchair, bed to commode, commode to bed, commode to chair. One person, two persons, hook methods, draw sheet, lift under thigh and shoulder. So here is, it's not a very, this is for healthcare. Let's see if I can, oh, sorry. Wrong one, let me just do this. No, it's not letting me do this. Okay, not to worry. So you have hospital workers, claims. So inpatient nurse, 430 claims for backache, back problems. Radiologic technologist is 95. Physical therapist, 25, because they should know how to do it. EMT, 14. OR tech, cardiac tech, nurse anesthetist. So basically it's the inpatient nurses, nurses' aides, and the radiology techs that bear the burdens of the lift injuries. So again, lifting patients, 22%. Pull up in bed. So what does that mean, pull up in bed? Pardon?
Setting the patient up?
Huh?
Setting the patient up in the bed?
No, this is in the nursing unit. This is basically if you have a patient lying in the bed and she's uncomfortable, so you lift them up so that their head is better on the pillow. How would you do that?
The bed itself. The thing lifts up.
Yeah, but the patient has to be higher up, physically higher
I
up
mean,
on
like,
the bed.
so the whole body up towards the head of the
Yeah.
bed?
Yeah, you're basically moving the patient up in the bed, physically up. So they're too low down. To get them more comfortable, they say, can you lift me up a bit? So that their head is a bit better on the pillow. And when you raise the head, you're not raising, the head's not down here, it's up here. So basically how you would do that is that if the patient was able to help you, one person on each side of the bed, your arm underneath their armpit, the other person on the other arm. You ask them to bend their knees and dig their heels in, and on 3, they push, you lift. So basically, they're pushing up and you're pulling up. So you're basically like this, and you're pulling up.
Where are your arms again? Around
They're underneath the patient's armpit.
Just both sides of your?
No, you've got one person on one side, one person on the other.
Okay, so you have 2 people.
So you've got one, you're actually lifting them that way. And if you're not done properly, you can twist, and that's the one thing that you should not do, is twist. So ergonomic protocol, patient assessment, you have to know what the patient can do. If the patient is not capable of helping you, then you have to do something else. If the patient just doesn't want to help you, then you have to do something else. So, here we go. Oh, missed. There we go. So here's a chart. So we start here. So can patient assist? Yes. Practically or not at all. 200 pounds, use a friction reducing device and 3 caregivers, which would be we're transferring to and from a bed or a stretcher or a bathing trolley. Okay, so you're transferring from the bed to a stretcher. So a friction reducing device would be something like a lifting board or a sheet. Partially not at all. Greater than 200 pounds. Sorry, this is greater than 200 pounds. 3 caregivers plus reducing. 200 pounds or less, reducing device. Can a patient assist? Yes. Caregiver assistance not needed, standby for safety as needed. So we have a gait belt, a A draw sheet, everybody should have those. A slide board, and the one I'm leaving out is a Hoyer lift, and you'll see them in a couple of minutes. So there's a draw sheet. You can see it doesn't go all the way down the patient. It starts at the shoulders usually, and ends about here somewhere, depending on the height.
So those are always on a bed?
Yes. And that's what you should do to lift. You don't want to, unless there's something specific, you don't want to take the whole sheet off the bed, unless there's no other way to do it. And the reason why I'm telling you all this is that in some departments, you may, especially in hospital departments, you may have to go up and get a patient from the nursing unit and bring them down for treatment. This is the problem. So you may have a couple of nurses to help you. You will have a couple of nurses to help you. So there's a gate bell. This is the white one is the one that most people have seen. This is a fancy dancy one, so you may not have never seen this. This is the normal one that you see. This is a chair, whoops, sorry. This is a chair which you can, unfortunately these don't work, so I'll send you the links. This actually moves into a stretcher. This is a hover mat, which basically you can lift, and it uses compressed air to actually move the patient or help move the patient. I've never seen a radiation therapy department with something like this. A roller board, which is something that some departments have. This is what they call a Hoyer lift.
I've used that.
Hmm?
I've used that.
Yeah.
It's a lot of fun.
It's good for people who are either too heavy or too awkward to lift. However, there's not many departments have them. It's a case of, you have to do some manual lifting. And there's, again, something like a Hoyer lift. Same thing, just different manufacturer. All of these are good. But remember, you have to get them from the hospital bed onto a stretcher, and then from the stretcher onto our treatment bed. Occasionally, you may have patients that come down in their hospital beds, not very often, but occasionally. And then you can move them from there to the bed itself. And there's one, and I believe we have one of those here in physical therapy. I think it's that one that we have, this one. But again, you probably would never see this in a department. So slip resistant sheets, draw sheets with handles. I've seen that. So it depends entirely, it depends entirely on what technical stuff that you have in the department. If you don't have it, then it's manual power. It's people power that you have to use. And this is when you have to have a good bag, and you have to know a technique on how to lift. Because it's no good practicing on all this wonderful tech stuff, and you go to a department that doesn't have anything. Then what do? Well, I don't know how to lift. They're not gonna accept that, sorry. You don't have a Hoyer lift? How do we lift patients without a Hoyer lift? Duh. Same way as we've been doing it for the last 20 years. Questions on that? Let's talk about, we've only got 5 minutes before the first group has to go across the hall. Let's talk about patients who come down with what I would call accoutrement, which means they have something attached to them. So what kind of things would be attached to a patient who would come down for treatment?
Oxygen.
Oxygen, yeah. IVs. What else? Catheters. You mean urinary catheters? Okay. What else? Those are the 3 biggies, but occasionally you will get someone with a chest tube. If you're really unlucky, you'll get someone with all of them. They've got IVs, they've got oxygen, they've got catheters, and they've got a chest tube in. Chest tubes aren't usual because that means they're really not stable, but occasionally you'll get somebody. So when you are moving a patient, guess what? All of this stuff has to come with them. And somebody has to be aware of where all that stuff is. There's no good pulling a patient from a stretcher onto the treatment bed if you leave the catheter behind, because that's an owie, right? So you have to make sure that you bring the catheter with them, or the catheter bag. Usually if they have a catheter and they're on treatment, they have a catheter bag. Everybody seen one of those? Everybody knows what I'm talking about? Okay. So, what do you do with the catheter bag before you start moving the patient? The patient's on a stretcher, for example, that's the easy way. The patient's on a stretcher, he comes down, you notice a catheter bag hanging on the side of the stretcher. You take the catheter bag off, and for the couple of minutes that it takes to move the patient, you put the catheter bag on the patient so you can see it, so you know where it is, okay? So you pull. However, if he has oxygen, if he has an IV, the IV is on a pole, right? You have to make sure that that has enough extra tubing in order to move it. Otherwise, you move it first and then the patient follows. Same with oxygen. Make sure that there's enough tubing that the patient's not going to get left in the nasal cannula when you move them, because you forgot that there's a tank underneath the stretcher. You didn't notice it. So you have to make sure all of that comes with the patient, which means maybe a couple of extra people to make sure that you're not leaving things behind. Okay? Okay, so I make it almost 10 o'clock. I'm just going to arbitrarily, since there's 5 here and 6 here, we'll go this 5 you guys first, okay? And it is by my watch, everybody check me, I make it 10 o'clock.
I think he's ready, I saw him. He
Yeah,
peeked out the
he was
window.
at the door.
Pardon?
He peeked in the window, so I think he was
Okay,
ready. He's not there now, but he did
okay,
peek and look.
come on, the first group, please come with me. And you have to get the patient off the bed in a hurry. And he's got IVs, he's got oxygen, he's got a catheter bag. What do you do with these? Supposedly you have to bring them with you, right? There is a type of machine called a Cobalt 60 machine, which isn't used in the US. It's used everywhere else in the world, but it's not used in the US. And it works by use of Cobalt 60, which is a radioactive isotope. Now, occasionally, very occasionally, the source, what is called sticks. It comes from a safe, and by compressed air, it pushes the cobalt along a tube and over into its treatment position. And then by compressed air, pushes it back. With me so far? Occasionally, that source will stick, either halfway out or halfway back, with the result that the patient hasn't finished treatment, but he's still being irradiated. So you have to get the patient off immediately. Get him out of the bed, off the bed, out of the room. The worst case scenario would be, the best case scenario would be that the patient is mobile and they can get off the bed on their own and move out. So you go in and you say, Mrs. Smith, we have a problem with the machine. I need you to get off the bed and out of the room as soon as we can. So one person goes in, helps the patient off the bed. We always had a house coat or dressing gown behind the door so we could put that over them and get them into a room. Worst case scenario, which actually happened to us at one point, was that patient was quadriplegic. He had IVs, he had oxygen, he had a catheter, and he had a chest tube in, and the source stuck. So we always leave the stretcher in the room with us. So what we did was we pulled the stretcher on, and we're pulling, and as soon as somebody hears there's a code, there's a source stuck, everybody comes to help. And one of the physicians actually came and we said, the IV was on the other side of the couch. And he looked at us and said, pull it. And we looked at him and said, what? He said, pull the IVs out. Okay, so we pulled the IVs out. We got we pulled the oxygen off. We got the catheter bag on the patient, and we all got to one side of the bed and we pulled and got him out. And we did that in 45 seconds. And got him out. Now, the chest tube was still in, so that was good. We didn't want to do that. Needless to say, we caught all hell from the nurses upstairs for pulling the IVs because they had great difficulty putting them in. Anyway, the doctor solved that problem. He just yelled at them. But this is the kind of thing that, there's no chance to be correct about how you move the patient. Just everybody gets on one side and pulls. Yes?
Don't they have things for like IVs where you can, it'll just be like a little thing where you can stop the IV and.
It would take too long.
But the nurses can't do that for you before you come.
No, you need the IVs running.
So you took the IV out
Yeah, we just pulled it.
when it's not running anymore.
But
It
I
was
was like
running,
an
but it was onto the
emergency
floor.
Thing.
Oh.
The problem with this scenario is that you have two choices. You wait and you do something with the IVs so that they're stopped and everything's hunky-dory. Or remember, this room is being irradiated. You need to get the patient out as ASAP, stat. So on the physician's orders, we pulled the IVs. It was faster than trying to fiddle with it, because we didn't have a nurse at that point. And the nurses would have been all nursey and want to do things, and we didn't have a choice.
So if the doctor hadn't been in there, you wouldn't have been able to do that?
Well, probably not. And that would have wasted a lot of time, and we would have got a lot more exposure, and the patient would have got a lot more exposure.
Now, are they, you guys weren't protected? You don't have anything on that protects you from that when you're?
You cannot. You can have, we had what they call film badges, which I'll show you later. But you're talking about lead aprons and stuff, right? Lead aprons are for diagnostic x-rays. The thickness of shielding that we need for these machines are about yay thick in lead. We could not possibly have lead aprons that thick.
So, do you know how much exposure you got with that, or? Did they let
We
you
got
know?
very little. We got very little.
So you were, yeah, so it wasn't something that put you on the sideline for a little while?
No, because the thing about it is when we're doing treatment with cobalt, we practice sore stick procedures once a month. So when one happens, which maybe once a year it happens, if you're very unlucky, you know exactly what you're doing. And we practice these. And we know exactly what we're doing, and we know exactly what to do when we go in there. So it's a sort of, like everything else, you do it often enough, even if it's on practice, that you need to do it.
So is that a malpractice
No,
situation?
no,
Or,
no. It's basically one of these things that happens with the machine. And you have to be aware of it, and you have to practice.
I can't
in order
imagine
to
how
know.
scared the patient must have been.
Patient knew nothing about it.
Oh, okay.
Basically, what we do is if the patient is mobile, we go in the room, and the idea is to stay away from the primary beam. And you say, Mrs. Smith, we have a problem with the machine. I need to get you out of the room as fast as we can. And that's basically what we do. The patients that are on a stretcher then we say, sorry, Mr. Smith, we're gonna have to pull you out. And we just grab and pull and get them onto a stretcher and out. And then explain what happened after that. There's no time for explanations.
But the couches don't move, right? They're not mobile. As far as they move, but not away from the beam.
No, we have to get them off of the treatment couch onto another, either walking or into a wheelchair or onto another stretcher. Okay? And that's something that, if you have somebody who is a little old lady of 80 and she walks in, but she sort of, got the chair going, the stick going, and takes her 5 minutes to get up on the bed, then in that case, you would pull a stretcher in and pull her off. You cannot wait for this little old lady to get down onto the stool and then down onto the bed or down onto the floor and then totter her way out the room. However, that's
Does
just,
that not happen with the linear accelerators?
no, because remember, the linear accelerators are X-ray based. The Cobalt 60 are I don't want that. The Cobalt 60 are radioactive substance based, so they never shut off. We shield them, but they never shut off. Okay, so let's get back to where we were. So I'm gonna see if I can show you this video.
So what we're going to demonstrate is a dependent lateral transfer from a stretcher to a bed. We're assuming the patient cannot assist with this transfer. So what we're going to do is we're going to maximize our safety and reduce the pressure on our back.
Anybody hear that?
Barely.
Okay, well, maybe we'll leave it for a minute then. Just ignore that for a minute. I'll send it to you. Okay. So this obviously is a very old photograph. And you can see that the patient they're doing actually a 3-man lift. White coats, white dresses and caps. Musculoskeletal injuries. The highest in healthcare occupations, the highest in the US. Rate of hospital workers twice the average, 76 per 10,000. Nursing home workers are 132 per 10,000. And ambulance workers are 238 per 10,000. Manual, single risk factor, obviously manual patient handling. Aging workforce, average age of registered nurse in the US is 47.
That's interesting.
Yeah. And they're training nurses that going out of style, but they're still aging. It could be that people feel that they have to work longer, or they want to work longer. Healthcare organizations are cutting workforce, so therefore, people are having to work longer hours and do more with less. So 52% of nurses experience chronic back pain. 12% leave the nursing. 20% transfer to a different unit due to back pain. Back pain is the leading cause of disability of nurses under 45. This is because people don't get taught how to lift. We can train nurses to use body mechanics and avoid injuries. You can teach how to use body mechanics, but do people use them? No. I can talk to them blue in the face about proper body mechanics and proper lifting techniques and proper moving techniques and stuff like that. You go into the field and you see somebody moving a patient that you think is wrong, but what the heck, you go with it. Experience relying on proper body mechanics and manual lifting alone is not effective. Patients are not comfortable or as comfortable or safe with mechanical lifting. They see this Hoyer lift and they think, I'm not having you put that on me. You've used a Hoyer. Do you have any problems with patients not wanting to have it done? Not wanting to use it?
I've never used one.
You've never used it? You've seen it?
No, yes, ma'am.
Okay. I've seen a lot of patients look at it and say, I'm not getting on there. You're not doing that to me. Well, sorry, Mr. Smith, but you're 350 pounds, we have to lift you. We what do? Patient education can reinforce that the lift is for patient safety as well as the caregivers. Patient handling equipment can prevent falls, bruises, and skin tears. As you get older, you see your patients who are 75, 80 years old. And has anybody seen older patients with tears in their skin? Their skin is very fragile, it's very thin, and you can look at it wrong and it tears. So you have a problem with that. You're trying to lift them, and for no apparent reason, their skin tears. That's something that you just have to be aware of. And the patient will say, "Oh, don't worry about it, dear, it's my skin." But you still feel bad when you see them and they're bleeding. And you think, "Oh God, the first thing is, did I scratch?" But no, you don't have to. Of course, that's the other reason why we don't have nice long talons. So it takes less time to manually move patients than to use lifting equipment. If you've never been taught how to use the equipment, yeah, it would take longer to use the equipment. But once you know how to use it, then it's pretty easy. Injury or disorder of the muscles, cartilage, spinal discs, etc. Pain may disappear after a rest away from work. Intermediate stage, body aches and feels weak soon after starting work and lasts until well after finishing work. And then advanced stage, it just doesn't go away. And that's when you have to think about doing something else. And if you have any of these, then you have a problem. Aching, burning, pain, swelling, cramping, stiffness, loss of color, tingling, numbness, or weakness. Wear the right clothes and the right footwear. Make sure your clothing and footwear are appropriate. Clothes should allow free movement, and shoes should be non-slip, supportive, and stable. That's why we suggest that you wear, these days, white sneakers, or whatever. And that's why scrubs should not be, as I saw somebody not so long ago, skin tight. You know, she knows which, so she orders a size smaller. No. Scrubs, you should be able to move in. They should be relatively loose fitting. You'll be bending, you'll be stretching, you'll be pulling, you'll be pushing. You should be able to move. Know your limits. Don't exceed them. If you need training in the technique to be used, tell your supervisor. Do one thing at a time, and then move on. Don't try to adjust the patient's clothing during transfer. Yeah. Before you start moving the patient, make sure they're covered. For the patient's sake, as well as everybody else's. You don't want to give a show to the people wandering up and down the hallway. So make sure the patient is covered, well covered, and then you can start to move. Prepare for a task. Make sure everything is ready before you start. Check that other caregivers are available. The equipment is ready. The handling environment is prepared. So make sure that you do not start moving unless you have all of your people in place. If you need 6 people and you only have 3, wait. Call for help. Call for assistance. Especially if you've done this patient before and you know that he's a big guy and it needs 6 people to help you lift. Makes sense, right? Common sense is the watchword here. And sometimes people don't have common sense, so just think about it. Apply safe principles. Always use safe body mechanics, rhythm and timing to aid the task. So, like we said earlier, person on the head starts the count. If we're going on 3, it's 1, 2, 3, lift. And you have to make that clear so that some people don't lift on 3 and other people are waiting till lift. 1, 2, 3, lift. Or you say move on 3, 1, 2, pull. Yeah. Load is often unstable. Patients don't have handles. Yeah. Patient weight is distributed unevenly and the patient may be combative. We don't get a lot of combative patients, thank goodness. But if you have somebody like this guy who has a barrel chest and slim hips, where is the weight going to be? On the chest. So you make sure that you have people that you know can lift or pull over the chest area. And if you have someone who's not really too sure, like a student, for example, just get them to guide the feet. Always have somebody at the head, the chest, and if necessary, the head, the chest, the abdomen, the pelvis, the feet. So with somebody that size, I would certainly need at least 6 people, maybe 8, to help him lift. If you cannot pull, you have to lift. And what did I say that the weight limit is on some of these beds? You remember? Talking about it on Wednesday?
350? Was that too much?
Actually that's too. Depending on the manufacturer, it can be anything from 350 to 450. So you have to know your weight limit also. And I'm not saying that if the weight limit is 400 pounds and you have someone who's 405, you're not going to treat them. You are. The problem might come if you want to get them through the CT. If you can get them through the CT, then you're probably okay on the treatment bed.
So all of that would have been discovered at planning.
You mean the weight?
Well, of course, the way, but I mean, the whether or not you could treat them on the bed that you have, they would know that, you would know by the
You would
planning.
know that by CT.
Right.
You need, if someone looks close to the weight limit, then you'd say, you hate asking the patient their weight, but if someone looks as if they're going to be close, then you say, I'm sorry, Mr. Jones, we need to weigh you. And you go ahead and weigh him and he's 405 pounds and you know that the treatment weight of the treatment bed is 400. Then you may want to go and speak to the physicist and say, look at, what do we do? Well, as long as you're careful, you can do it. And remember, we raised the bed and then moved it out. You're really stuck with that. And you have to be extremely careful.
What happens if you can't treat them is there other treatment options?
No,
So somehow you gotta figure out how to.
somehow
treat
you
them.
gotta figure out how to treat them. Even if it means, I'm sorry, Mr. Smith, you'll have to lose 10 pounds before we can treat you. It's a fait accompli, you know? You have to do it, and there's no other way around it.
So did you see that often, or?
I've seen it 5 or 6 times. Actually more than that, but yeah. So, what's commonly taught are body mechanics and the principle of ergonomics. So stand in a stable position, feet should be shoulder width apart, one leg slightly forward to help your balance. Avoid twisting. Make sure your shoulders and pelvis stay in the line. Bend your knees. Elbows in. Tighten abdominal muscles, head up, and then move smoothly. Oh, that's been next door. Okay. Maintain a wide, stable base with your feet put in bed at the correct height. So waist level when providing care. Hip level when trying to move a patient. Why would it be lower when you're trying to move a patient? Because you need to have it at a correct height in order to pull or push.
Why waist level when you're?
Because if you're caring for the patient, like changing the bed, changing the sheets, then you want it at a reasonable height so you're not bending over to change the sheets or puff the pillows or whatever you want to do. But remember, if you're moving him from the bed to a stretcher, you want them both on the same level. And these things, the stretchers, do not go up and down. They're set at that height. Try to keep the work directly in front of you and keep the patient as close to your body as possible. Okay, science of fitting jobs to people. Where did the other two go? Oh well. Okay, in patient care occupations, forceful and heavy exertions. High frequency and repetitive tasks, awkward postures. We should not have awkward postures, ladies. Oh, there you are. Wondered where you'd gone.
Sweet.
Are they back?
Yes. They? Karen.
Oh, them.
Huh? That was fast.
Yes, we did, I think maybe 2.
We did the wheelchair lift, everybody took a turn on the wheelchair lift and from chair to bed, and then he demonstrated the draw sheet to
Okay.
go to bed, so he's ready
Okay.
for the next group whenever.
Right, where's? Oh, there he is.
Okay,
Okay, guys. Come on back. 1, 2, 3, 4. Where's the other two?
Fun.
Okay, I'll shoo them in.
What could you possibly do?
You did good though.
Sorry.
Okay, I wanted to like speak to somebody when you like, okay, you ready? Oh my god, so unexpected. We should just talk.
Are we ever doing?
Yeah, we usually do too much.
That was a small wheelchair though.
Yeah,
That was so uncomfortable.
it's actually pretty standard. Some of those big ones, you can barely get through
Yeah.
the doors, like you literally have to switch the
I
patient
think I
from
prefer
wheelchair
French
to
one.
wheelchair through doorways,
I
because they
get-
won't go through.
If I ever get pulled, I'm gonna
Okay.
get an electrical chair.
Okay.
So what did you learn?
A lot.
How to position the patient.
Mm-hmm.
How to position your body when lifting them with the gait belts.
Yes.
And putting them into bed.
Okay. And what else?
how to shuffle them on and off the patient table.
What do you mean by shuffle?
Move them from the gurney over to the patient bed
And how did you do that?
with a sheet.
With sheet,
Yes, ma'am.
okay? What happens if you don't have a sheet on?
He showed us how to tuck one under, how to pull them up, tuck the sheet
Roll them over
under,
and then
roll them
Yeah.
in, pull them under.
Okay,
and then move them.
okay. So we didn't do anything about with a moving board or anything like that?
He said he didn't have a.
Okay, that's fine, okay. So I was going over, I did shut it off. I was going over a scenario that we faced. There are certain things that you need to rehearse. In Canada, we had a machine called a Cobalt-60 machine, which works on radioactive source cobalt. And unlike the linear accelerators, which we also had, occasionally what happened was that the source would stick. So the source sits in a safe, and then compressed air would move it from the safe into its treatment position, would go along a tube and sit in the treatment position. And when the treatment was done, again with compressed air, it would be moved back into its safe position. Occasionally, on its way back, the source would stick, which means that the radioactive source is still pushing out radiation. We have to get the patient out from under there immediately. If the patient could move, if he's a walking, talking type of guy, you could go in and you could say, Mr. Smith, we have a little problem with the machine. I need you to get off the bed and come out immediately. And we'd have a house coat or dressing gown to put over the top of him and get him into a room. That would be the best case scenario. Worst case scenario, which we had at one point, was a patient who was a quadriplegic. He was on oxygen. He had a catheter in. He had a chest tube in, and he had IVs up. And the source stuck. So when everybody hears the source is stuck, everybody arrives to help, including the physicians. So we had a physician going into the room with us, and we said, we have an IV up, and he said, pull it. And we looked at him and said, excuse me?
Mhm.
Pull it. So we just pulled the IVs out, and we took the oxygen off. Chest tube, thank goodness, was there. So everybody got on one side of the bed, and we pulled them onto a stretcher and got them out of the room in 45 seconds. Now you may say, why did we pull the IV? You tell me why. There was a choice. We could either waste time getting the
Yes, 'cause
IVs
you'd have to
around
wheel
to
it
the other
all the
side of
way.
the bed and wheel them out, or we could just pull the IVs and get them out that way.
Put another IV in.
The problem is, all the time we're in the room, the patients are getting exposed to radiation, we're getting exposed to radiation. So we have to get them off the bed immediately. So in that case, what we did was we pushed the stretcher up against the treatment bed, and everybody got on one side, and we just pulled on the sheet, and the patient came over. It wasn't the best move we'd ever done, and it was a little rocky, because everybody was pulling at the one time, but we got him out of bed, we get him out of the room, and everything was fine. Except that we got hell from the nurses upstairs for pulling the IVs. However, the doctor solved that problem because he yelled back at them and said, look, this is what happened. Deal with it. So anyway, Did he go over the same thing as I did, the swivel from the,
His technique, on
Was
the
probably a
foot
little
placement
different.
was a tiny bit different. He didn't put the foot in between the legs, he
Mhm.
put it on the outside, but I also think the way he did it, so he would, if he swiveled, if you're sitting down,
mm-hmm,
and this is my left leg, he placed his foot on the outside but pressed his knee in.
yeah,
That
Yeah.
still have a brace.
yeah, it's all in, what you find easier to do. But it's the same technique, it's just a different
A little bit
way of
different.
pushing, yeah. And if you have from stretcher to bed, it tends to be that. So we were going over things like ergonomic risks of the patient, dependence of the patient. Here, lifting heavy loads, excessive pulling and pushing and reaching. This is a 2-man lift. So basically what you would do is you'd lift the patient, you'd take the arms off the wheelchair and you just lift them like that. It's called a chair lift. And that can be done from patients sitting on the bed, patients sitting on the bed like this, here, and one person would go underneath here and under their back, and you'd lift. And that's what they call a chair lift. So more than one person required to lift, and this is basically what I was saying earlier, is you call for help. You say, lifters needed on, Linac, whatever it happens to be. And you would get enough people to help you lift. And then you have the Hoyer lift, which is very good if you have one. Very few departments have one. So you may have to, sorry?
I said, he looks like he's just swinging.
Yeah. Yeah, some patients aren't really comfortable with a piece of equipment lifting them. Here's another one.
I'd like to see the mechanics of getting them into it. That's still gotta be kind of a task to get that.
Well, basically what you do is you have them lying down and you roll them, put the lift sheet underneath them, and then it hooks up and sits them up,
Oh,
and then
okay.
lifts them over.
Reminds me of the old way of weighing babies.
Yeah,
Oh,
Yes.
how did you used to weigh babies?
yeah.
I was about to.
They used to have a little sling thing that
Yeah.
they would put them on. I don't know what they were called,
They
but
put the
did.
baby in the
Some
sling?
midwives still use them, like
Yeah.
traveling midwives.
Yeah.
Okay.
So there, so you have to be careful. We were just discussing that if you have somebody, remember we were talking about weight limits on our bed, our treatment bed on Wednesday. And we're talking about something like 350 to 450 pounds, depending on the type of machine you have. So we would be, we would have to think about that. If a patient comes in and he looks like he's on the cusp, you may have to ask him to get weighed, or you may have to go and weigh him.
You don't have access to their chart to see, because they have been weighed recently.
Well, it depends on whether this is a brand new patient. Remember, if you're in CT, you haven't seen this guy before. He's not in a hospital. This is a standalone center. You don't have access to charts per se. So this might be only his second time in the treatment in the department. So they may have weighed him on his first day, but you're responsible if he is above your weight limit on the CT or the treatment bed. You're responsible for checking with the physicist before he gets anywhere close to the bed. Because if he gets onto the bed and something goes wrong, whose fault is it? Yours. So if you run it past, you weigh him, and he's 405 pounds, and you know the treatment machine bed weight is 400 pounds, then you would have to take it to both the physician and the physicist and say, what do we do with this guy?
Have you had that happen?
Mm-hmm.
So have you had to refuse him treatment because of this?
No,
or-
we don't refuse treatment. What we would suggest is that they lose some weight before we treat them. So it may only be a matter of 10 pounds or 15 pounds. And they can, at that weight, they can probably do it in a couple of weeks. So by the time, a couple of weeks come along, they're under. And that doesn't mean to say that everything's great, because you still have to be careful because they're on the limit. You have to be careful on what you do with them. Characteristics of an unsafe lift. Both co-workers and equipment. If you're not using a mechanical lift, you're using basically people's power, as it were. You want to make sure that you know what you're doing, and what's more, everybody else knows what they're doing. Okay? Okay, what can you see? Okay, so the patient is upstanding. He's got a walker. Okay, what do we see? Patient may have difficulty supporting his full weight, hence the walker. Patient begins to fall, what will the nurse do?
Only hold up one side of them.
Where is she? She's on one side of the patient. Is she in a position to help if the patient falls?
He starts to crumble to his left side, towards her maybe. But
Mm-hmm.
If he goes down fast, she's not gonna be able to support both sides.
And usually, if they're unstable, that's what they do. They may, you notice the bed's right behind them, so he may just sit down again, which is fine. But if he crumbles, there's no way that that person can help him. Can a nurse support full weight of the patient by herself? No. Is the patient wearing non-slip footwear, or is the floor slippery? Well, we don't know. But what do the patients have?
walker. Well, he's got a walker.
Well, he's got a walker, but what do the patients usually have on their feet?
Those slip grip socks.
Hopefully, yeah. If not, bare feet, maybe. Or worse still, normal socks. Normal socks are killers. They will slide. So we don't want them. They can put slippers on, normal slippers, which usually have a non-stick sole. But the fancy socks are better, the non-slip socks. Or their bare feet for that matter. Although not many nurses would allow the patient to run around in these bare feet. Germs, yeah. patient is not strong enough to push up with his or her hands into a sitting position, place one of your arms under the patient's legs and the other arm under his or her back. You've got a patient lying on the bed. You say, okay, Mr. Smith, you can sit up now, and he just lies there. How are you going to get him up? You put one arm underneath his arm, put one underneath his back, and lift. Move the person's legs over the edge of the bed while pivoting his or her body so that the person ends up sitting on the edge of the bed. So when you're sitting up, you've got the patient's head here, the feet are still on the bed, so you want the feet hanging over the edge of the bed and the head here, swiveled. And keep your feet shoulder width apart, your knees bent and back in a naturally straight position. So eventually, you're going to have him or her stand and go in here. So again, pivot, you get up, pivot, sit. What happens if the patient has a stroke or he's not good on one side? How do you move him then?
Use the side he's good with.
Pardon?
You go to the side that he can use.
You go to his good side. That's what you're saying, right?
Yes.
Yeah, so help him in his good side. But he's in a wheelchair. And you know that he is weak on his left side. Where, this is the bed, this is him, where would you place the wheelchair? So he's weak on his left side. So at the moment, I'm in a wheelchair. This is my weak side.
Okay, you need to turn the other.
Turn the other way. Okay, we can do that. So the good side should always be closer to here. And you may need some extra help for that. Depending on how mobile the patient is, if you can stand and he's not too weak on that bad side, then you may be able to just do a swivel and sit. You really have to know your patient. Place your arms around the patient's back, clasp your hands together. The patient is wearing a lifting belt. Grasp the belt when lifting the patient. This is a good one. Difficult one sometimes. Putting the patient from a wheelchair into a car. It's good, it's actually better coming out of the car because you're going downhill. But if you're taking the patient back to his car or her car and he's in a wheelchair, you basically stand, turn, or swivel and put the patient against the car. And if he can manage to help himself, then you may be able to get him in. If not, then you have to basically lift him in. And that happens too. Repositioning him, chair. And there's your Hoyer lift. So you can see how it works, and the sheet or the Hoyer cover is underneath him. And then they just attach and lift. Okay. So I've actually pointed out, this is what I was talking about when I was saying that you should kneel on the bed. Look at the lady's Let me get it. Okay. So I think what they're doing is pulling him or her onto this mobile bed here. So, design of the room. What's wrong with that? Her back is straight.
But it's not supported because she's got no leverage with her hips down.
Yeah. So in this case, the idea is that she would get on her knees, put one leg up onto the bed, and that would give her some purchase in pushing or pulling, whichever way she had going.
Because I feel like if she's leaned over like that and she's lifting with her arms, even though her back looks straight, like her lower back is pulling.
It's basically an accident waiting to happen.
Right.
It's an injury waiting to happen. And if she continues with that for another couple of years, she's going to be injured. She really is. Yeah, well, duh, yeah. Posture of caregiver could lead to an injury. Okay, so again, education, competency. So there's it's a fancy dancy lift. Sit to stand lift, transfer belt, non-friction device. So you want to make sure that if you're using equipment, you know how to use it, and is it correct for the patient that you're using it on. Make sure that if you're lifting patient, there's no other furniture between the patient and where you want them to be. You've got bedside tables, you've got little lockers on the side, you've got oxygen tanks, you've got suction equipment, you've got all sorts of things back here. My goodness. Okay. Born in a barn. Or a pub with swing doors, one of the two.
But I think I took my glasses over there.
Okay. So you want to explain the task to the patient, obviously. You want to know if you have a patient that's lying on a bed and you're transferring them to another bed or the treatment couch or back to their hospital bed. You want to know, you want to make sure that the patient knows what's going to happen. Okay, so you don't want to do something that the patients have never done that to me before. Or the ambulance guys bring them in on the stretcher and you pull them across, but normally they lift them across. It can cause kind of havoc to the patient. They don't know what's happening.
They were on me, right here. Always the case. Oh my gosh.
Okay.
That was embarrassing.
No comment.
Did they point it out to you?
No, I realized it after I walked out, but I'm sure he was looking at me like, lady, they're right there.
I'm surprised you didn't say nothing.
So, yeah, okay. So I have a video, but the sound wasn't very good, so I'll send it to you along with what we need. So prepare the patient. Ensure the patient's clothes and footwear are appropriate to the task. They may have any aids that they need. Adjust their clothes and aids and position. For example, encourage the patient to lean forward. Okay, so the patient is coming in for treatment. The ambulance has just picked them up from a nursing home to come in for treatment. And they get to the department and they're in Street clothes. They've got a shirt and pants and shoes and everything else on. And you're going to be treating the pelvis. So you have to make sure that you can actually get into the patient's treatment area once the patient is on the bed. So you make sure that the pants are easily pulled down. If the patient is able to lift his butt so you can pull the pants down. If not, you lift it for him and you pull the pants down. So that's the other thing that you have to do. And then you have to make sure that he knows you're going to be moving across and, you know, okay, I can do this on my own. I don't need any help. Yeah, okay. So you say, okay, well, let's see what you can do. And he's sitting on this and he goes like, and you think, okay, this is going to take us forever doing this. And we say, okay, Mr. Jones, please just lie still and let us do the work. But it's okay, we can do this. Okay, so you just put your arms across your chest and breathe normally and we'll do the work. Okay. Well, that was good. Yeah. A lot of the older gentlemen, it's still a female-dominated department most of the time. The older guys don't want young slip of a girls to lift them and to help them. They want to do it on their own. This macho stuff comes out, you know, especially the older guys. And until we actually move them, they don't realize that we can do this.
Yeah.
You know, so you have to make sure that the patient knows exactly what we're doing. Otherwise, it can lead to chaos. I've had patients almost fall because they wanted to do it themselves.
It's like pride.
Hmm?
They just can't put the pride aside.
Yeah. So they've basically said, oh no, I can go off the stretcher and onto the bed. No, you can't.
But can you do it within a 5-minute time frame?
Yeah, exactly, yeah.
Instead of 5.
But no, I mean, you give them a chance, but 9 times out of 10, they'll say, oh, maybe not. So, clear instructions. This helps the caregivers and the patients to work together. So what you do is you tell Mr. Jones that he's going to put his arms across his chest and he's just going to lie still. And we'll move him. You'll hear us saying 1, 2, 3, go, or whatever is useful in the department. And you gather everybody together and you say, okay, 1, 2, 3, and pull, or lift, or pull, whatever you happen to want to do. And you look at the patient and say, is that okay? Yeah, that's good. Sometimes they're worried that they're going to get dropped. They're going to get hurt. So you have to be extremely careful with them. So sit and stand lift, sit to stand lift. Transfer a gait belt. Non-friction device, which is the lift. Something like the, sorry, just going out of my head here. The backboard, the moving board. So standing for an extended period of time. Stand with your feet shoulder width apart, place one foot slightly behind the other, and shift weight from foot to foot. Reposition your body if possible. Bending over a long period of time. Every so often I do this too. Bend backwards slowly and come back to an upright position. If I've been standing for a long period of time, I tend to do that. Sit or stand with the arms loosely at sides, turn your head to one side or the other, and repeat 3 to 4 times. Has anybody ever done this one? Yeah? Or that one? Okay. So basically, musculoskeletal disorders. If you do not know how to lift, these can cause an end to your career. Body mechanics, totally. Lifting device where it's possible, if you have any, or practical, but sometimes it's not practical. A lift team in the event the patient is very large or overly obese. This is when you say, we need lifting help and as many people as possible. 8 people maybe, 6 people definitely, if the patient is rather large. Never put yourself in a position where you or your patient should be injured. You do not lift a patient unless you're sure you can do it correctly. If there's only 3 of you on a machine, patient's on a stretcher, you need help. Minimum 4 people. Maximum as many as you can get. Okay. So again, it's just body mechanics to start with. So these are the muscles that you can strain. Makes sense. Your biceps, your hamstrings, and your abdominal muscles. So there's a normal, there's a wide stance and a narrow one. Try and do that when you're, yeah. Okay. So center of gravity, everybody knows about the center of gravity. Where is it? It says it here. Mid portion of the pelvis or lower abdomen, depending on the body build. If you don't put your base of support over your center of gravity, you can tilt. So center of gravity is there. S2. So, good, not so good. And many people have actually done this without even thinking about it. Yeah? Been there, done that. Don't want to do it again. This is correct, or this is as correct as it gets. Provide a broad base of support, work at comfortable height, bend your knees, lift your back, or keep your back straight, keep your load well balanced, and roll or push heavy objects. Avoid pulling or lifting. So, patient comfort. So, lordotic is concave, kyphotic is complex. So it says padding placed underneath the body. In some times we can do that, other times we cannot. It's impossible. We cannot treat those patients with a lot of padding underneath them. Why? Anybody get any idea why we can't put a lot of padding underneath?
Can affect your depth dose, depending on what material.
Yeah. More basic than that. what are we trying to do with our patients? We're trying to put them in a position which is relatively comfortable, but we can reproduce every day. Now, if we have a lot of padding, we cannot reproduce that exactly every day. We may have a little more padding on one side than the other, so we keep to a bare minimum the amount of padding that we can give to these patients. We may there's a black pad that's about 2 inches thick, 1 inch thick, that we can usually put underneath the patient if they're not comfortable. If they're palliative, we can do that, but that's probably the bare minimum that we can do, or the maximum that we can do. Patients are better able to maintain position as needed. Yeah, however, can somebody tell me what this is? Yeah. What's the common name for those?
Bed sores.
Bed sores. We don't see them as much anymore. We used to see them quite a bit, but we don't see them as much anymore. But when you do see them, they're really nasty, and you have to be careful. What causes them? Sorry?
Pressure.
Pressure, okay.
Laying there for too long.
Laying in one position for too long. So theoretically, they should never happen. So why do they happen?
Maybe because the patients in the bed don't move that much.
Okay.
The nurses or people caring for them don't move them enough.
Basically bad care. Very bad care. Patients should be, if they're lying in a bed for long,
2 hours.
they should be moved every half hour or so from one position to another, so that they're not lying on their butt all day, or they're not lying on their side all day, or their back all day, or whatever it happens to be. They should be moved. It's basically just bad patient care if you have cubitus ulcers. So, patient will be in one position on an X-ray table for longer than 10 minutes. A full-sized radiolucid pad should be used. Now, we very rarely use the pad, simply because we need to keep the patient in one position every day for a set period of time. And this is radiology, so we have to be a little more careful. If the patient is having, say, a radiographic procedure done, it looks like they're all set up to do catheterization or some such, then they're going to be on the bed for a while. Maybe half hour, 45 minutes, something like that. Very rarely are our patients on the bed for that length of time. Patient positioning. So supine we know, prone we know, lateral we know, Sims position, and Fowler's, or semi-Fowler's I should say. So semi-Fowler's is the head up, the legs straight. Sims position. That's what we used to call in CPR a recovery position. Does that ring a bell with anybody?
Mm-hmm.
Yeah, okay. So that's a recovery position, or the Sims position. And then we have the Trendelenburg and the lithotomy position. So transport, you see this is the backboard that you see them put the patient on. Anytime where you think there may be a spinal injury, you have to be extremely careful with their head. Extremely careful. If, for example, we have a patient who comes into the treatment room or into the CT room with a cervical collar on. Everybody knows what I mean by a cervical collar, right? It's either a soft or a hard collar. What's the difference between a soft and a hard? A soft collar is foam, and it's usually about yay, and it goes around and it velcros in the back. A hard collar is actually, it goes way up here and way down here, and it keeps the neck very still. Soft collar you can sort of do this with. Hard collar you can't. So if we have to treat the neck, you have to take the seat collar off. And this is when you take the collar off, you put the mask on. But if you have to move them from the stretcher or the hospital or the EMS stretcher or the hospital stretcher to the treatment bed, you move them with the collar on until they get onto the bed. Then you very carefully take the collar off and put the mask on. It's very, very carefully, very carefully. Okay, get transport. Okay, so this is the stuff that can be around the hospital bed. So you have cardiac monitors, you have a bedside table, you have a chair, you have the hospital bed themselves, you have all the equipment at the back there, all of this stuff. And then you have to get a stretcher in to get the patient off of the hospital bed onto the gurney to get them down for treatment. So you've got all this stuff that you have to finagle around. And believe you me, it's these beds don't move these chairs, they may look nice, but they don't move very easily. Enlist the patient's help and cooperation. Obtain additional help when necessary. Check to make certain your assistants understand their role in the transfer. If you have somebody that you call for help, and probably a couple of therapists will come in and help you, and then maybe a physicist will come and a physician will come, they have no idea how to lift. The doctors certainly aren't taught how to lift. The physicist, well, just stands there, looks at it, okay, what do you want me to do? So in that case, you would direct one of them to move the feet or guide the feet. The physician usually does that. He's really good, they're really good at that. And then the physicist will maybe just hold the bed, because you don't want a non-clinical person helping. And the physician, for all that he thinks he knows, isn't counted a clinical person. So you have to be careful on what you give these guys to do. So wheelchair, lift and rotate the patient into a sitting position. Help the patient with slippers and robe. Okay. So the legs hanging over the edge of the bed. This will allow patient time to regain a sense of balance. orthostatic hypotension. Remember we talked about that last week or the week before? What's orthostatic hypotension? Anybody remember?
Like movement, increase blood pressure, move.
Yeah, so
Or decrease.
if you've been lying down for a length of time and you suddenly sit up, so the patient's been lying down and you sit them up and swing the legs over, they'll tell you, sorry, the room's spinning. And you say, okay, just sit there until the room stops spinning. Meanwhile, we'll get the shoes on, the slippers on, and maybe the robe on, just to give them time for their head to stop spinning. At this point, some patients will be able to stand and get into the wheelchair on their own, but other ones will not. First thing, of course, is make sure the wheelchair is locked. There's nothing worse than having the patient stand there and put their hands on the wheelchair and it goes shing because you've forgotten to lock it. Very embarrassing, if nothing else. So here is transfer from bed or chair. So the transfer belt. So this is somebody doing it on their own. So we've got the transfer belt. Some people will say to the patient, move a little bit to the edge of the bed, edge of the chair. Did Dr. McClafferty mention anything about that? Yeah. And then you can lift them and turn them, swivel, and sit them down. The only problem here is that you'll probably end up with their gown way up here. So you want to make sure that they've enough gown that you can keep them decent, shall we say. So, yeah. So they'll swivel and then sit. So there's your wheelchair and the table. So there's a two-person transfer. So the arms around the patient and lift and turn them, and then they just sit them down. Here's the lift, the Hoyer, and lift them. And then you can swivel them. There, this one up top is a sliding board. So you roll them, put the sliding board underneath them, and then you can pull them over. And if you need to take the sliding board away, which we may have to, you can do that as well. So again, here is this is an actual sheet. This is not a draw sheet. This is an actual sheet that we're moving it with. So if you only have 3 and you feel that you can do 3, then that's fine. But look at the position of these 2 ladies. Is that good or
Not good.
not good?
They could unfurl the sheet some to have more reach.
Yeah. Yeah. And you notice that this lady at the bottom here has got her hand underneath the feet so that she's also pulling the feet across. But because she's cocooned in a sheet, everything should go over themselves. And that's why you don't really roll the sheet, you just pull the sheet themselves. It gives you a lot more movement and you're not leaning across the bed. Questions? Okay, so when you guys left, we were talking about the extra equipment that the patient comes down with. So what kind of extra equipment will the patient come down with? What is attached to the patient? I'll let these guys answer because you guys all know it. Okay, what stuff is attached to the patient that may come down with them? IV, oxygen, catheter, okay,
Chest tube.
and perhaps a chest tube, although that's unusual. So if you're moving the patient, it is ideal that all that equipment comes with them. There's nothing worse than the patient's on the stretcher and you pull them and the catheter's still attached to the stretcher. It can be very uncomfortable for patients, to say the least. So where do you put the catheter bag? The catheter bag is actually hanging on the cot side of the stretcher. Where would you put the catheter bag?
You would lay it on them.
Yeah, for the couple of minutes that it needs for you to pull them, then you just pick up the catheter bag, put it on their legs so that everybody knows where it is, you can see it. What about the oxygen? Or the IVs? You have to know where they are. If there's an oxygen tank, it's usually underneath the gurney or underneath the stretcher. So you have to make sure you know where that is. The IVs are always on an IV pole of some sort. So you have to know where that is. So everything has to come with the patient. You have to make sure you have enough oxygen tubing to stretch. You have to make sure that you've got enough IV tubing to stretch so that you're not pulling stuff out accidentally. Because believe you me, you never want to do that. And you don't want to strangle the patient with the oxygen tube or anything silly like that. So you make sure that the oxygen tubing is maybe at the head of the bed so that it can be moved with the patient, or certainly the IV tubing has to do it than that. So that's the thing that you have to be careful. It's not just moving the patient, it's moving all of the accoutrements that come down with the patient. The catheter obviously works by gravity, so you should have it below the patient. Same with the chest tube. It works by gravity, so you should have it lower than the patient. So it's hanging on the side of the bed or hanging on the side of the stretcher. And you have to make sure that comes with the patient. Otherwise it can be very uncomfortable for the patient. And uncomfortable for you if you have to write out an incident report because, oops, you forgot about the catheter. And it came out of the patient, which can cause very much damage. Why? Why a catheter, if a catheter comes out, would it cause damage?
It's too fast.
Pardon?
It's too, fast, rough,
Yeah.
It can, right?
Friction, that soft tissue.
Has anyone seen a urinary catheter? There's a bulb that gets filled with air once it goes into the bladder.
So that doesn't come out?
And if that, it can be pulled out, believe you me, I've seen it happen.
Try hard enough.
Yeah. I've seen a patient actually take a catheter out with the bulb intact. It is not funny. Anyway, it was actually, but. But that's why it would cause damage, because if the catheter bulb is full, the size of the ureter or the size of the urethra, trying to get that bulb out,
How large is the bulb?
well, it's probably about that size.
Okay.
And the urethra is tiny.
Yeah.
So, yeah, it would be extremely painful for the patient. So I'd rather not attempt it.
Is it called a Foley bulb?
It's a Foley catheter, yeah. And the Foley catheter has a bulb on the end
Yeah.
that you fill.
Okay.
Yeah. Questions on either what Dr. McClafferty taught you or what we've seen? I'll send all these videos to you along with the YouTube video that I never got to show you because it was kind of strange. Any questions? Okay. So it is almost 11:30. Let's stop for lunch and we'll